record button. There we go. Perfect. All right. Hello, hello. Welcome. As the first of you start rolling in, I'm going to give it a couple of seconds just for internets to connect and all that fun stuff. And let me change it so you can actually see who's talking. There we go. Hi. Okay, welcome. We've got a bunch of new names, actually. This is really exciting to see. So if you're joining us today at Gilda's Toronto for the first time, welcome, welcome. We're happy to have you. And if you're a familiar face, welcome back. Always lovely to see you again. Well, to see you again. I'm going to get rolling. It is 6:02. So welcome to this evening's education session. We are very, very excited to be having presenters sharing us today about lung cancer screening. Before we get rolling on the actual interesting part of this presentation, I do have to go over a little bit of housekeeping with you all. This is a Zoom webinar, so we cannot see you, we cannot hear you. The only way for you to get in contact with myself, who am I? I always forget to introduce myself. My name is Gloria Lausch. I'm the virtual program coordinator here at Gilda's Toronto, and I will be your social/technical support for the next hour. So if you want to get in contact with me, please drop a message in the chat box and I'll be there to support you, monitoring that throughout the next hour. If you would like to ask a question to one of our wonderful presenters that we have this evening, Mika and Maya, please drop that in the Q&A box or in the chat box, whichever one suits your fancy a little bit more. And they'll be answering these questions throughout the presentation, but also dedicating some time at the end, but they'll explain a little bit more about that. Like I said, webinar, can't see you, can't hear you. So those chat box and the Q&A is really the only way that you can get in contact with us. Maya and Mika have very kindly allowed us to record this presentation this evening, and we will be sending it to all registrants afterwards. So no need to take any crazy notes or, feverishly break pens through paper. You can watch this on demand afterwards whenever you would like. Finally, if you ever at any point before, during, after have questions, comments, concerns, or anything you'd like to share with the Gilda's Toronto program staff, please send us an email at program@gildasclubtoronto.org and we'll be able to answer you, help you out, and all of that stuff. Now, finally, what we are really here for and what we care about is our two wonderful presenters. We have Mika Sharma and Mika Sharma today who will be sharing their wealth of knowledge with us. Maya and Mika Sharma are studying Biomedical Sciences at the University of Guelph. They are members of the Canadian Lung Cancer Screening Initiative. Maya is currently a lung cancer research assistant. So please, I will now stop sharing my screen and give all the power over to Maya and Mika. Thank you.
Thank you for the warm introduction, Ms. Lausch. I'll just begin sharing my screen here. Okay. Okay, thank you, everyone. My name is Mika Sharma, and I'm for the Canadian Lung Cancer Screening Initiative, or CLCSI for short. And today we'll be giving a presentation on lung cancer and lung cancer screening. We're very grateful for the opportunity to present to you today. So as mentioned earlier, if you guys have any questions, feel free to put them in the chat throughout the presentation, and we'll dedicate some time at the end of our presentation to go over every single one of those questions.
Before I get started into the content of the presentation, I'd like to share a little bit about what the Canadian Lung Cancer Screening Initiative does. The CLCSI is a sister organization to the American group, the ALCSI, which is a 501c3 nonprofit that works to raise awareness for lung cancer and lung cancer screening. We hope that in educating communities about lung cancer and lung cancer screening, high-risk community members will be encouraged to seek lung cancer screening. Today, we will discuss both lung cancer and lung cancer screening, addressing questions such as how common is lung cancer, what is lung cancer screening, and how you can get screened. Lung cancer is very common. It is the second most common cancer in Canada, excluding skin cancer. It is the leading cause of death from cancer for both men and women in Canada. This graph shows the Canadian Cancer Society estimates for the number of new cancer cases in Canada. This graph estimates new cancer cases in 2022 for the 4 most common cancers. And as you can see, it is estimated that 30,000 people will be diagnosed with lung cancer in 2022 in Canada. It is estimated that about 7% of people will develop lung cancer during their lifetime in Canada. And that means 1 in about every 14 men and 1 in every 15 women will be diagnosed with lung cancer. Moreover, not only is lung cancer very common, it's sadly also very fatal. Lung cancer is the leading cause of cancer-related death in Canada and across the globe.
In 2022, it is estimated that lung cancer will claim the lives of 20,700 Canadians. This graph shows the Canadian Cancer Society estimates for the number of cancer-related deaths in Canada. As you can see, lung cancer is far more fatal than breast, prostate, and colorectal cancer, actually causing more deaths than all of these 3 cancers combined. Lung cancer makes up almost 25% of all cancer deaths in Canada, resulting in about 350 deaths each day. And every year, there are 4,570 more new cases of breast cancer, but lung cancer will cause over 15,000 more deaths. From this data, the question that arises is, why is lung cancer mortality so high? Well, lung cancer mortality is so high because people are often diagnosed at a later stage.
This is a graph looking at the proportion of patients with lung cancer by stage. Stage is a way for doctors to classify a cancerous tumor based on tumor size, if the cancer has spread to the lymph nodes, and if the cancer has spread to other locations in the patient's body. The higher the number, the greater the spread of disease in the body of origin of the cancer. Nationally, nearly 50% of cases are not caught until a late stage. So why is this important? Because the stage at which the lung cancer is diagnosed correlates directly with survival. We'll see this in the next slide. One way that doctors track the survival of patients is by looking at the 5-year survival. As you can see here, the 5-year survival for lung cancer at early stages is high, but the 5-year survival significantly drops as the disease progresses. And this is why early detection of lung cancer is very important. If we can detect lung cancer at an early stage, then treatment options are better and prognosis is better. With lung cancer being such a morbid disease, some of you might be wondering why the majority of lung cancers are diagnosed at a late stage.
Well, the majority of patients are diagnosed with late-stage lung cancer because they don't begin to feel any symptoms until the cancer has already grown and already spread. The most common symptoms of lung cancer are chronic cough, coughing up blood, chest pain, and shortness of breath. Additional symptoms may include hoarseness, loss of appetite, fatigue, persistent lower respiratory infections, and an onset of wheezing. However, when people become symptomatic, cancer has already grown to the point where it's difficult to treat and the prognosis is quite poor. If the diagnosis of lung cancer has to wait until the patient has symptoms, it's difficult to catch lung cancer early. So the question we ask is, how do we catch lung cancer early if patients are asymptomatic? One of the best ways that we can do this is through lung cancer screening.
Lung cancer screening is done using something called low-dose computed tomography scan. If you are eligible for lung cancer screening, it is recommended that you are screened. In the coming slides, we will discuss what lung cancer screening is, who should get screened, and how to get screened.
An important distinction that we want to make is that lung cancer screening is done using a low-dose computed tomography, also known as low-dose CT scan, and not the chest X-ray, which you can see here. We use a low-dose CT because it provides more detailed pictures than the chest X-ray and is better at finding small abnormal areas in the lung. The picture on the left is a chest X-ray. The yellow areas point to abnormal areas in the lungs, but it's not very clear. On the other hand, the image on the right is of a low-dose CT scan of the chest, and the red area is pointing to the abnormal area in the lung. As you can see, this image is a lot more detailed than the chest X-ray and enables you to see the abnormal area in the lung with greater clarity. The question that researchers wanted to know is how effective is low-dose CT at detecting lung cancers at such an early stage, and the importance of this was highlighted in the National Lung Cancer Screening Trial, or NLST. NLST was a national large-scale study with over 50,000 patients. The goal of this study was to determine the effectiveness of using the low-dose CT scan to detect lung cancer in patients considered high risk for lung cancer. The study included two groups, a group of patients who received an annual low-dose CT scan and a group of patients who received an annual chest X-ray. By comparing the stages at which cancers were caught between these two groups, the study wanted to determine if low-dose CT was better at catching more lung cancers at an early stage.
As you can see, of everyone diagnosed with lung cancer, the low-dose CT scan caught the most lung cancers at an early stage, while the X-ray diagnosed more patients at stage 4. This has important implications for survival, because the low-dose CT scan caught more lung cancers at an early stage, and these cancers were more likely to be treatable, and the prognosis was much better. This translates to 20% reduction in mortality for those who underwent lung cancer screening using low-dose CT compared to an X-ray.
A concern with any screening test is its accuracy. Essentially, how good is low-dose CT at catching lung cancer early? For every 100 individuals undergoing CT lung screening, 25 of them will be positive and 75 of them will be negative. Of those 75 that are negative, 97.7 to 100% truly do not have lung cancer. This means that the test is very good at identifying people who do not have lung cancer. That is, if you do have lung cancer, the test will most likely come back positive and the test will not miss your cancer. Out of the 25 individuals who are positive for lung cancer, 23 of those actually turn out to be negative for cancer, primarily with a follow-up imaging alone. This means that if your test results are false positive, it's really easy to rule out cancer further using non-invasive imaging. The two individuals that are positive and truly do have lung cancer are more likely to be diagnosed at an early stage, and if they were to have not gone any screening at all. This means that their treatment options and prognosis are much better. The results of this NLST were published in 2011, 11 years ago now, and several studies have been published since then, further to confirm the life-saving benefits of lung cancer screening. One of the most important recent trials was the Nelson trial. In February of 2022, the results of the Nelson trial were published. Like the NLST, the Nelson trial had two groups. However, unlike the NLST, the Nelson group had a group that received a low-dose CT screen and a group that had no screening of any kind. A total of 13,195 men and 2,594 women between the ages of 50 to 74 were randomly assigned to the CT screening group at T0 baseline, and 1 year, 3 years, and 5.5 years, or they were assigned to a group with no screening, the control group. The results confirm the life-saving benefits of lung cancer screening by low-dose CT. In the screening group, 58.6% of lung cancers were diagnosed at stage 1, and in the non-screening group, 13% of lung cancers were diagnosed at stage 1. Early detection translates to a reduction in mortality. In the low-dose CT group, there was a 24% reduction in lung cancer mortality in men and a 33% reduction in mortality in women compared to no screening. The Nelson trial also showed that with improvements in low-dose screening technology, the false positive rate was reduced significantly.
Lung cancer screening significantly reduces lung cancer mortality, but who should get screened for lung cancer? Right now, the Ontario government has in place the Ontario Lung Screening Program, or OLSP. Determining if you are eligible for the program is a two-step process. Moving forward, we will refer to each as Step 1 or Step 2. The OLSP recommends that people between the ages 55 to 74 who have a 20-year smoking history, meaning that you smoke every day for 20 years or greater, reach out to the program. This can be done one of two ways. Your family physician or nurse practitioner may refer you to the program, or individuals who may contact an Ontario Lung Screening Program site hospital on their own to have their referral inclusion criteria assessed. This is the first step in determining eligibility. From there, if eligible so far, an Ontario lung screening program site, Hospital Screening Navigator, will contact you to conduct a risk assessment. This is step 2. The results of the risk assessment in step 2 determine whether someone is eligible to be screened for lung cancer through the program. We will go over more detail about each step in the coming slides.
As you mentioned, there's 2 ways to go about step 1. One option is to talk to your family physician or nurse practitioner about lung cancer screening. They'll ask you some questions about your smoking history and other aspects of your medical history to make sure that screening will be right for you. If you meet the recommended criteria, then your physician may recommend for you to go to step 2. Alternatively, you can also self-present to the Ontario Lung Screening Program through contacting a hospital site directly. So you can call an OLSP site hospital on your own and have your smoking history and your referral criteria assessed. And on the same initial call, you may be able to jump straight into the second step of determining eligibility, which we'll go into more detail.
Regardless of if you went through your family doctor to be referred or contacted the OLSP directly, your healthcare provider will play an important role in helping you get screened. They can help answer questions you may have or the risks or benefits of screening and help you decide whether getting screening is appropriate for you. Your family physician will complete a referral form for the Ontario Lung Screening Program. If you contacted the OLSP directly, the OLSP will ask you that you provide them with the name of your family physician so that OLSP may reach out to your doctor and have them complete the referral form for you. If you are found eligible at step 2 and do not have a family doctor, the OLSP will help you find one.
So here are a list of hospitals currently participating in the Ontario Lung Screening Program, taken from the Cancer Care Ontario website. So you're encouraged to contact these hospitals directly with any questions that you may have about the program or to find out if you qualify. I'll also leave the numbers and everything on the last slide. So feel free to jot them down then or when you rewatch this recording. In addition, healthcare providers can refer individuals who live outside of any of these OLSP hospital areas. And if the referral is accepted, the healthcare provider must work with the OLSP to make sure that the appropriate diagnostic and follow-up is honored. So this slide provides a good summary of the first step in determining eligibility for your lung cancer screening.
You may be eligible in the first step if you are 55 to 74 years old, are a current or former smoker who has a 20-year smoking history, meaning that you have smoked cigarettes for at least 20 years, but periods of smoking can be added together, so it does not have to be 20 years in a row, or are covered under OHIP, except for Quebec resident. So you may not be eligible in the first step if you have been diagnosed with lung cancer, are under surveillance for lung nodules, are currently undergoing diagnostic assessment, treatment, or surveillance for life-threatening conditions, for example, a cancer with poor prognosis, as assessed by the referring healthcare provider, or if you have had hemoptysis, coughing up blood of unknown cause, or unexplained weight loss of more than 5 kilograms in the past year. If you're experiencing any of these symptoms, please contact your physician.
If eligible so far in step 1, you move to the second phase of determining your eligibility. In step 2, regardless of whether you were self-referred or referred by a physician, an OLSP site hospital screening navigator will conduct a risk assessment by telephone to determine whether or not you are eligible for screening through this program. The screening navigator will ask you questions about your age, cigarette smoking history, body mass index, education, personal history of cancer and chronic obstructive pulmonary disease or COPD, and family history of lung cancer in particular. Your answers to these questions will help determine your lung cancer's risk and if screening is right for you. The assessment is actually a going to spit out a risk of your likelihood of getting lung cancer in the next 6 years. And people with the risk of 2% or greater can participate in the OLSP. If you're eligible based on the risk assessment with a screening navigator and you've worked with your family physician to complete the referral form, you'll be screened through the OLSP.
If you're eligible for lung screening, your information will be sent to the CT department located at a participating hospital. The CT department staff will then contact you to arrange for lung screening appointment. One thing to stress is that this process will not hurt at all, and because it's a low-dose CT scan, you do not use contrast. This means that there will not be any needles or injections involved. The low-dose CT scan is non-invasive, fast, and completely pain-free. On appointment day, you will be asked to remove any jewelry. You will not need to take any special medications, receive any needles before your scan, and make sure that you please wear comfortable, loose-fitting clothing without any metal, so you do not wear a belt with metal fastenings or bra with underwire. And the reason for this is that metal objects might interfere with image results. After arriving for your appointment, a technologist will bring you to the imaging room for your low-dose CT scan. As far as how the experience of getting a low-dose CT scan goes, it will require you to lay on your back for about 5 minutes. You'll be doing something very similar to the patient in the photo here, and you will lie face up on the scanning table with your arms resting above your head. Once you are positioned, the table slides you into the donut-shaped scanner. During the actual scanning, motion will degrade the quality of the final images, same way that affects photographs. So you will need to try and keep as still as you can. You'll be asked to hold your breath for a few seconds, and the scan uses small amount of radiation that will take detailed images of your lungs. The actual scanning will take less than 10 seconds and is not painful.
So you talk to your family physician about lung cancer screening, and you've gone to get your screen. Now what? So the doctor will go over the results of your screening test and follow up with you. So as far as results go, if your scans are normal, then the patient can talk to their physician about repeating scans in the future. And you're encouraged to receive screening annually. But it's also important to monitor your health for any unusual changes, even if there were no concerning areas found on your most recent lung scan. If the scan indicates that you may be positive, then you'll undergo some more testing to determine if the area of concern in your lung is truly lung cancer. And you'll be asked to come in for a follow-up CT scan to monitor any changes in the detected area concerning your lungs. If your lung scan is very suspicious, you may also need a biopsy.
Just to reiterate, if your next step is another low-dose CT scan, it's important to come back for your next scheduled scan. Screening works best if you get tested regularly. If your next step is being sent for more testing, you need more tests to find out whether you have lung cancer. You'll be contacted by a member of the lung diagnostic assessment team to talk about your next steps. Being sent for more tests does not mean you have lung cancer, but if you're diagnosed with lung cancer, the lung diagnostic assessment team will talk to you about your treatment options and help you decide what is best for you.
Additionally, while lung cancer screening has the potential to save many lives, it's also important to address smoking cessation in the context of lung cancer screening. Lung cancer screening is not a substitute for smoking cessation, and likewise, smoking cessation is not a substitute for lung cancer screening. Smoking cessation is one of the best ways to prevent lung cancer, and lung cancer screening is one of the best ways to detect the disease early. Using both is the best way of fighting this disease. For every year after an individual quits smoking, the risk for lung cancer is reduced by 8%, from 25% to 17%. However, we understand that smoking cessation can be very difficult, and there's a lot of resources for people who are trying to quit smoking. You can talk to your doctor if you're comfortable to determine a good course of action to help you to quit. The OLSP will also offer free smoking cessation services regardless of whether or not you did qualify for the program.
After smoking, the next leading cause of lung cancer is exposure to radon gas, which is released from soil and can build up indoors. Moreover, secondhand smoke causes almost 3% of new diagnoses of lung cancer and is expected to cause about 3% of deaths from it in 2022. Additional risk factors include exposure to asbestos, a family history of lung cancer, COPD, and previous radiation therapy to the lungs. It is important that we recognize these additional risk factors because although lung cancer has a strong association with smoking, there are a large number of people in Canada who have never smoked that will still get lung cancer.
Lung cancer can also occur in never smokers or individuals who smoke less than 100 cigarettes in their lifetime. Because lung cancer has such a strong association with smoking, people are often surprised to learn that lung cancer in never smokers occurs to about 10 to 20% of lung cancer diagnoses and is the 8th leading cause of cancer death in the world. More never smokers die from lung cancer each year than people die from ovarian cancer.
This graph shows the proportion of lung cancer cases that occur in people who have smoked in their life and people who have never smoked. It is then further broken down by whether they are a current, former, or never smoker. As you can see, 80 to 90% of lung cancers occur in people who have smoked during their lifetime, and about 10 to 20 occur in never smokers. Right now, lung cancer screening is not recommended for individuals who have never smoked. However, understanding lung cancer in never smokers is a current focus of research. With the development of new screening technologies and risk models, there may be a way to identify high-risk never smokers who should be screened for lung cancer.
Another question that we often get is about how vaping and e-cigarette use affects lung cancer risk. Vaping and e-cigarettes are a relatively new phenomenon and have become more prevalent in the last decade. While the long-term effects of vaping and e-cigarettes are still being studied, it's clear that for individuals who have never smoked before, they can increase their risk of lung cancer. E-cigarette devices and vaping fluids contain nicotine derivatives and heavy metals, among many other chemicals. They arise as both elements of the e-liquid and a result of organic reactions in the electronic cigarette device. Various studies demonstrate in vitro transforming and cytotoxic activities of these derivatives, meaning that they can cause cancer. Vaping causes fewer health risks than smoking, but it's certainly not a risk-free activity. Vaping can increase heart rate, decrease air volume in the lungs, and increase airway resistance. Furthermore, the e-cigarette device use of this device has been rising significantly, particularly among young adults and non-smokers, making it a significant area of concern for the future.
In summary, lung cancer is the leading cause of cancer-related death in Canada. It is so deadly because most lung cancers are diagnosed at a late stage when they have spread to other locations in the body. Importantly, early detection through lung cancer screening by the use of low-dose CTs can reduce lung cancer mortality by up to 33%.
As this presentation comes to a conclusion, we want to end on what we at the CLCSI have been doing to spread awareness, education, advocacy efforts necessary to increase the lung cancer screening rate. Lung cancer is the deadliest cancer in the world, and while lung cancer screening can save so many lives, very few high-risk individuals are currently being screened, and we're working to address all aspects of that issue. We've been giving webinars such as this one to educate a variety of different audiences about lung cancer screening, including students, healthcare providers, community leaders, policymakers, and even healthcare departments in the United States. And we believe that through educating communities, especially students like ourselves, or people who are vocal about health promotion, it can really make a difference. And the more you're able to share about lung cancer screening with people you know, and people who may be high risk, it really does make a difference. So thank you everybody for engaging in this presentation, and we'd be happy now to answer any questions you may have.
Thank you so much, Maya and Mika. That was wonderful.
Thank you guys.
I really appreciate how you broke down the steps, what people can expect when they actually go into these screenings. I think that's really important. Thank you. We've got
You're welcome. Thank you so much.
Sorry, there's a delay.
Oh yeah, so I'm just looking at the questions in the chat now. Somebody asked, are there screening programs for patients who don't meet the eligibility for OLSP but have a very strong genetic history of lung cancer in the family? your genetic history is taken into consideration as part of your risk assessment. However, there is no other screening program in Canada, in Ontario rather, I should say. BC has a formal program, but if you don't meet the referral criteria for the OLSP, unfortunately, you can't be screened through the program. Somebody else wrote, would I be at risk as a non-smoker for the past 35 years and not exposed to secondhand cancer? If you maybe mean secondhand smoke, as unfortunately, as we mentioned in the presentation, if you're a non-smoker, currently you're not eligible to be screened through the program. Although you mentioned that you were never exposed to secondhand smoke, which is a good thing. Unfortunately, you cannot be screened through this program, as right now they're really just trying to focus on people who are at the highest risk, and those are people who have smoked cigarettes for themselves for 20 years. How to identify high-risk non-smokers? That's actually a really good question. It's an area of research right now that's being looked at a lot. They're working on different risk prediction models. As we touched upon in our presentations, an area of current research. Ontario just began this OLSP in 2021. So there's a lot of improvements that can be made, and hopefully as research advances and more inclusion criteria become verified by evidence, OLSP will modify their guidelines accordingly. And I think that's all in the chat.
Awesome. All right. Thank you so much again, Maya and Mika. That was really wonderful. And thank you to all of our registrants and people who are attending today and who will be watching this video afterwards for taking the time to educate yourselves and to pass this message along as well. It's been a wonderful evening learning with you all. You will be sending, like I said, a recording of this webinar. So be waiting for that in your inboxes shortly. And that's that. Thank you, Maya and Mika. Good night.